सर आप एक बार चेक करना चाहते हैं स्लाइड्स? इज इट डन?
Fine.
That's
Okay,
it?
I'll just check it.
Yeah. Once you are done, then we will start.
I'll check the slides.
I'll stop sharing, then you can do. Now you can check.
Uh,
Yeah,
okay.
I think we can see the slides, sir.
Screen is moving. Screen is moving. Slides are.
Yes. Video you can check once. This is all moved.
Check the video.
Yeah, ठीक है. Okay.
Okay, fine.
We'll start off, sir.
Yeah.
Yeah. I think good evening, everybody. Welcome to this webinar on calcium and complex PCI. Basically, we thought to create some awareness among the coming TCT India meeting in July 26, 27, 28. We'll conduct series of such webinar programs, and then probably all the doctors who logged in will also create more awareness, and the faculty will be automatically faculty in TCT. And with this, to start off, I requested Dr. P. Sirath sir, who is a present CSA president, our senior colleague and great help in any program. He readily agreed to cooperate. Along with it, requested the seniors, Dr. Tripti Dev Madam, Dr. N.V. Raidu, Dr. K.R.K.S. Raju and K.M.K. Reddy, they'll be also joining. The idea is to take interesting topics and each time you discuss in little more details, coming with more of case-based approach, showing some case examples. And that's how this program is also designed. And initially, sir will be talking about a newer technique of orbital atherectomy. Then I'll show some case in a box example of calcific lesions. Then we'll have the case presentations by colleagues who will have what is the role of DES and DEB combinations in bifurcation and calcific left main by Varsha, and osteal LCX and RCA disease image guidance by Ramakrishna, and graft PCA, some of the newer senses will cover. I want it to be more interactive. Feel free to discuss and stop in between. And this is program is being live streamed on the YouTube channel of TCT India, where about 300 plus doctors have logged in. I think that might go up. We generally have about 750 subscriptions already for that. With this, a few words of introduction, I request Dr. Rath sir to say a few words of welcome. Then give some chance to Dr. Raidu sir and Dr. Tripti madam. Then we'll go on to your lecture, sir. Over to you, Dr. Rath sir.
Thank you, Dr. Srinivas, for organizing this very interesting meetings on management of calcific coronary artery lesion. This is a very burning topic because around 25% of our cases we have to do nowadays complex cases. 25% of the patients are calcific lesions, and the approach to calcific lesions are different. And it's very important that this bed is prepared well so that the stent expands well so that the subsequent mass is reduced. So that's the whole idea. We have many calcium modifying devices we'll be discussing, starting from cutting balloon, rotablator, orbital atherectomy, and IVL. And I think at the end of the meeting, we'll have a clear-cut idea about how to use these techniques and where to use it. With these few words, I request Dr. Raidu and Dr. Triptidev to speak. Dr. Raidu, you can start your just few words before we start the meter talk.
Yes, a very good focus on calcific lesions because it is a common problem as the population is aging. More lesions, more calcific lesions we encounter. And there are various modalities now available, not like earlier, only rotational atherectomy was the only available instrument and with a little more complications. But now IVL and orbital atherectomy has changed the scenario. And now the calcific lesions are more amenable for angioplasty and stenting. And the restenosis rate with modern modalities are also less, and MACE, as you pointed out, is less with the modern modalities. I think now the rotational atherectomy has have become a historical aspect. I think now no longer probably useful in future. Probably these few comments, I ask Dr. Ratha to present his
Dr.
the
Tripti madam,
recent
before
modality on
before
orbital atherectomy.
yeah, before that, sir, Tripti madam, are you there?
Yeah, I'm very much here.
Yeah, you can say a few comments, then we'll go to Sarath sir's lecture.
Yeah, actually, when I was looking for the literature of ACC-AHA guideline as Sky Coronary Artery Revascularization Guideline in 2021, it has given a 2A level of evidence for coronary interventions with imaging. Exactly speaking, how to optimize our levels of evidence recommendations for the use of intravascular ultrasound for procedural guidance, particularly for the left main or complex coronary artery stenting to reduce the ischemic events, and for the use of optical coherence tomography as a reasonable alternative to IVUS for procedural guidance, except for ostial left main disease. Using pathology as a gold standard, the diagnostic accuracy of IVUS or OCT to detect dense calcium is very high, more than 90% sensitivity and specificity. On IVUS, calcium is seen as a bright echoes with acoustic shadowing, while on OCT, calcium appears as a heterogeneous area of low backscatter with low attenuation and clear borders. Both IVUS and OCT can measure the arc and length of calcium, whereas only OCT can accurately measure the thickness of the calcium. Although OCT provides higher resolution images, it is more limited in depth of imaging when compared with IVUS and requires blood clearance. I hope all our participants and the great cath lab operators have taken the imaging facilities for all the complex coronary calcium oriented treatment and to get a best optimal results for the long-term treatment of the calcific coronary artery disease, which are highly challenging. So I congratulate Dr. Srinivas Kumar for bringing out this very complex scenario, which we face day to day in the cath lab, as Dr. Rath has already spoken about. 25 to 50% of patients have superficial or deep or nodular or so many varieties of calcium. I am very thankful to Dr. Srinivas and FACS Foundation for bringing such a for the novel concepts to be and the learning objectives to bring it to our clinical practice. Thank you very much.
Thank you, madam. I think KMK and others can speak later. We'll request now Dr. Ratha to talk in more detail about orbital atherectomy. Over to you, sir.
I have 15 minutes with me, I think.
Yes, sir. Yes.
Just in the first slide. As I have already told that this is going to be a common problem, calcific coronary artery disease. And as the patients are getting, population is getting aged, we'll be getting more and more. Now, roughly around 25% of the patients undergoing PCI have moderate to severe calcification. So we have this type of things available. We have this cutting balloon available. We have rotational atherectomy available, orbital atherectomy, and intravascular lithotripsy. The cutting balloon is good, but it doesn't. It's not very good for dense calcification. It's fine, mild to moderate is okay, and it's not sufficient to cut the calcium adequately for the stent to expand fully. So that is the first. If there's a mild, moderate calcium, we can use it. But next is a rotational atherectomy, and it has the, as you know, it has the different types of bore. You use around 75% of the size according to the vessel wall, vessel thickness. But the most important, it has lot of problems. It has got a lot of high risk of no flow, rib flow phenomena, perforation, and complete heart block, all these things. Whereas in orbital atherectomy, the crown rotates around, and crown size is around 1.5, 2 point, and it's moves forward and backward. And it's is usually used in a larger vessel more than 2.5, and no temporal occlusion of the vessels, no flow reflow phenomena, and doesn't take much time. Whereas intravascular lithotripsy doesn't, it's good for the deep calcium and ideal for a large vessel, and it usually cracks that calcium so that the stent expands well. But the downside is it's bulky. If the lesion is tight, you have to dilate it with balloon, and then only you can put it. Next one, please. Next one, this one. Okay. This is the comparison between rotational atherectomy and orbital atherectomy. As I have told you that rotational atherectomy is unidirectional and front cutting. Risk of bore entrapment is always there, and no flow, row flow phenomena is much more. Whereas orbital atherectomy is a bidirectional differential standing and pulsatile force. It's an eccentric mounted crown created centrifuge force. Allows for continuous blood flow during the procedure, so that no flow, reflow, no flow phenomena is much reduced. Next one, this. Next one. Next one. Yes, this is a comparison again between lithotripsy and orbital atherectomy. Lithotripsy is a balloon designed to modify calcium without atherectomy. It doesn't cut the calcium, it just tracks the calcium, mostly in the middle deep calcium, and cracks intimal and medial calcium without removing it. Limited to investigate. It's a very good tool for, as I told you, large vessel, deep calcium, and in instant restenosis especially, it's unique, because you cannot use other orbital atherectomy or rotational atherectomy instances, but lithotripsy you can use. So in orbital atherectomy, as I told you, is bidirectional differential standing and pulsatile force is there. Bidirectional differential standing, it cuts the superficial calcium into small pieces. But the pulsatile force, to some extent, cracks the deep calcium. It reduces the intimal calcium through differential standing. Deeper plaque may be affected by pulsatile mechanism, but all this, but it usually doesn't harm the tissues, non-calcified tissues in the wall. Next. This is the device description. Basically, it is a simple device setup, and microsecond is usually 130, length of the edge around 135 centimeter, compatible with 6F guide catheter, is eccentric diamond coated crown, and saline infusion is there. There is a specific guide wire called Viper where that is used, and this Viper slight lubricant is used for during the procedure, and you have a very simple 1.5, and you can modify the speed 80,000 to 120,000. That's the first year. So this is basically a simple device compared to the rotational atherectomy. Next. This Viper guide wire is very specific for this. It has to be used. You can see the crown, and the length of the guide wire to the nose cone is around 5 millimeters, so you should be aware about it. You should keep a distance during the procedure. And shaft is 135 centimeter total shaft. Next. Again, dual mechanism of this procedure, bidirectional differential standing, reduces the superficial calcium, and pulsatile force, that deep calcium it cracks by pulsatile force. Next one. This is just to show the mechanism. Average particular size is less than 2 micron when you do the and bidirectional standing is usually affect cause the superficial calcium. Healthy elastic tissue flexes away from the crown, minimizing damage to the vessel. So that is what I was telling. And the pulsatile force which the rotating crown creates, cracks the deep calcium. And it is important that you should know about it. When you move, it should be moved around less than 1 to 2 millimeter per second. By that way, the crown cuts more. If you move faster, it doesn't. It just speeds. It doesn't cut that much calcium. But if you, that's why it's recommended that you move it very slowly, 1 to 2 millimeter per second. And when you're doing it, you should be very careful. Always look at the viper wear tip, the spring. It should be kept away, and you should look at, when we are doing it, you should image it. Because if you find that wear migration is observed, then stop the EA. So this is just to make sure that the wear doesn't break down. So you should, when you are doing it, you should keep the spring tip in appropriate distal position and keep the spring tip in imaging field vision. Next. This is how it looks. This is a pre-OCT, severely calcified nodule. And after this orbital atherectomy, you can see the fracture of the nodule. And it also has ablated the superficial calcium. And in end, you can see that stent is well opposed. Next. This is just a
This illustration of the mechanism of action of orbital. What it does to the heavily calcified lesion is provide standing.
This is the comparison between the rotational atherectomy, orbital atherectomy, and IVL. If you look at the deep calcium, maximum deep calcium modification takes place with the IVL, to some extent with orbital atherectomy, but rotational atherectomy doesn't affect the deep calcium. Then, if there is a stenosis is very tight, then you should use rotational atherectomy or orbital atherectomy. IVL will not go. IVL require the stent, it has to be dilated, lesion has to be dilated before using the IVL. And instant restenosis, only IVL to be used, not this where orbital atherectomy or rotational atherectomy. No flow or slow flow phenomena is seen as a complication, maximum with rotational atherectomy, very minimal with orbital atherectomy, none with IVL. Dissection resection is high with rotational atherectomy. Not that much, it doesn't occur with IVL, minimal with rotational atherectomy. Perforation is high with rotational, orbital atherectomy. It can occur with rotational atherectomy, but it's a little higher with orbital atherectomy. Success rate is the highest with rotational orbital atherectomy, 97.7%, whereas in rotational atherectomy it is 92% and IVL is 92%. MIS, short-term and long-term MIS is a little higher with rotational orbital atherectomy, and compared to a short-term is 30 days MIS is 5% with rotational atherectomy, 10.4% with orbital atherectomy, 7.2% with IVL, whereas 1 year MIS is 15% with rotational atherectomy, 14.4% with almost same. Long-term outcome is same. Little higher MIS rate with within a month with orbital atherectomy. Just contraindication of orbital atherectomy, if the lesion is uncrossable, guide where it doesn't cross, then you cannot do it, obviously. Graft, stenosis, and instant restenosis contraindicated. If there is a thrombus in the target lesion, again, it's contraindicated. Already, if there is a dissection, you shouldn't use it because it will further dissect. Single functional coronary artery disease, it is a little unsafe. You can use it, but relative contraindication, pregnancy and children not recommended. Some trials, this is the first Orbit 2 trial, which next one, which shows that it was a 443 patients at 49 US centers. Procedural success was around 88.9%. Successful stent delivery was 97%. In-hospital MACE was 9.8%. Next one. And dissection was 3.4%. Perforation was 1.8%. Perforation rate was little high in this Orbit 2 trial. Next. But MACE rates it was in 1 year, 2 year, 3 year is almost same like the ES implantation. So nothing much in this. Next. After this, it was Orbit 2 trial. It was recommended to be used in calcified lesion, and that's after that only it has been approved. Next. The new trial, Eclipse trial, this is to evaluate the treatment strategy for severe calcific coronary arteries, orbital atherectomy versus conventional angioplasty prior to implantation of drug. In this case, the large trial ongoing, more than 2,000 patients, multiple centers in USA. In 400 patients, they are doing imaging during and after the procedure. Result will be, I think, next year it will be announced. Next. Just show you some of the cases. The first case is 65-year-old male and diabetic, class 3 angina. The next. So this patient actually attempted outside for PCI to the RCA calcified lesion, but they couldn't cross the balloon. When they crossed the balloon, couldn't deliver the stent. So patient was referred here. We did the intravascular ultrasound. Can you see the intravascular ultrasound? Just heavily calcified. Just 1 minute. Just see this heavily calcified. You can see heavily all around calcium. Heavily calcified at right. You can see it. Short. Heavily calcified. This you can see it now. Heavily calcified. Coronary artery disease, critical lesion in the mid part. So we did the orbital atherectomy for these patients. Next, so the orbital atherectomy. And next, next, 2.724 stent, and next, 3.20, 3 into 20 DS. That's the final result. You can see that. Just go and show that result here. That's the result. So it's very excellent result. Heavily calcified mid RCA, which was stent was initially, it was not possible to put the stent, though they had abandoned the procedure. We did it with the orbital atherectomy, and this is the result. Next one. There is another case, 78-year-old male, diabetes, COPD, angina, and ejection fraction was normal. Single vessel disease, LAD and D1. Next. There's the heavily calcified LAD and D1, and we did the OCT for this patient. Next. We did the OCT, no? Yeah. Okay, first we have done the OCT, I'll show it to you, but we did the orbital atherectomy, and next. What the next? And this is the OCT before. You can see, you just show the place. Show the place where there is a crack. There's a dissection here. You can see the dissection after orbital atherectomy. You can see the this is dissection again. Go no, so that there is in you can. This is the no, not this one. Go slow, go slow, go slow. These are all no. Go back. I have seen it. This you can see the crack there. Go back. Go back near the go forward. Go forward. Here you can see small cracks, but what it produces a lot of dissection. There are some small cracks in the superficial calcium. And deep calcium, there are a lot of deep calcium that was not affected, and we put a stent. Good. We put a 3.523 and 2.528 stain, 2 stains, and the result, just show the result. Okay. That's the result. Excellent result. Looking at the complexity of the lesion, heavily calcified lesion, result was excellent. Next one. This is the, after the stent was implanted, the stent have been well expanded, well apposed. You can see it now, well apposed stent. Okay, so stent is well apposed. That's the result. Next one. Last case is just show this 82-year-old male. These are all elderly patients, calcific lesion, ejection fraction is 30% go. And that's the result, heavily calcified circumflex artery, long lesions, and also critical lesion, the LAD. So what we decided, LAD lesion didn't look calcified, but circumflex lesion was calcified. So did the orbital atherectomy for circumflex lesion, and go ahead and put 2 stents. And next, put 2 stents in the circumflex, and next, and we did a LAD. We just put we dilated. There's not much of calcium in LAD, so we put one LAD. We just directly stented with 2.524 and 332 long stents, and that is the result. Remember, this was an 82-year-old man with ejection fraction of 30%. So this is the result. Angiographical looks excellent, and we didn't do, because of the severe LV dysfunction, we didn't do any OCT. Intravascular ultrasound catheter was not going. So angiographical result was good, and this heavily calcified circumflex artery was possible to dilate and stent only because of the orbital atherectomy. Next. So in conclusion, calcification significantly complicates PCI and compromises the outcome. Orbital atherectomy addresses calcification and vessel compliance. It's suitable for balloon uncrossable lesion, effective in nodular and deep calcified lesion to some extent. But single device can be used in one orbital atherectomy catheter. You can use in multiple lesions in the same patients. And during the procedure, there is no minimal risk of low flow phenomena, so risk of ischemia is much more reduced, and as a slow flow, no reflow phenomena is much less. And of course, it needs more randomized data with contemporary DS platform. Ongoing trials is Eclipse, and 2 cases is the size of the vessel is very important. Less than 2.5 millimeter, it should not be used. Second thing is instant restenosis, not recommended to be used. Thank you very much for attention.
Thank you, Rat sir, for covering it so well and highlighting some of the important aspects of orbital atherectomy and showing good case examples. Many of the doctors, for sake of others, also have doubts regarding, even Raidu sir was telling orbital atherectomy, once it is coming, rotational atherectomy will it go almost. But Rotaflex, the modifications of rotational atherectomy, what they did had covered some of these advantages of this newer device. But for that, the backward cutting, it's stuck bar, all that is still possible with Rotaflex also. But what are your thoughts, sir? Rotational atherectomy, the standard one, where are you still use it?
It is in heavily calcified vessel. It is rotational atherectomy has a role, and many times this also may not go. Orbital atherectomy, the calcium is heavy and long lesions, and that time rotational atherectomy has a role, definite role. And with this new, yes, easy to use nowadays, but it has a role. But as I told you that here again this complications like dissection, perforation, a little more than rotational atherectomy. That you should keep it in mind. So rotational atherectomy in heavily calcified lesion, which are very tight lesion, and this has a preference over the rotational orbital atherectomy.
Thank you, sir. I think we can have some questions in between as session go. Right, sir? Trupti madam, anything you want to say before we go on to that?
That is a very good coverage of on orbital atherectomy and with illustration cases. I think we'll go on to the next session.
Yeah. I think what I wanted to just briefly present is some of the things which are not covered by Dr. Atsar, and also show you one or two cases which we recorded in cath lab, and some doctors requested me to show briefly how to perform this OCT. For seniors it could be repetition, but I request all of you to tolerate it a little and show you some of the newer modification of OCT catheter also, and take you through this live in a box case recording highlighting the importance of bed preparation. This slide brings best vision of Apollo Group of Hospitals. As this is already covered, why we are so much bothered about calcium is basically it increases the safety risk and impedes stent deliverability. Where you want to take the stent, it can't go, and prevents the stent expansion. Those are the reasons why we still want these such sort of devices where, I think 1 minute, where we need to prepare the bed well. That's covered already. And the impacts, the calcium is increasing, the outcomes, death, MI, TLR, and follow-up will increase significantly. That's why we need to have devices to cover all this. Some of the technical considerations, what I thought I'd briefly mention for sake of juniors is we need to have a good guide catheter support. These are some areas where we could still take 7 French catheter and femoral if possible. But most of the times we do with radial. Nowadays with radial 6 in 7 French catheters coming up, even the 7 French one we can use through radial. That is a slender sheath of Termo. And then guide extension catheters, long sheath, support wires, all these should be kept available in the lab. And low profile delivery stents, the most of the stents are good enough now. And this latest third generation stents make this possible. Lesions, again, highlighted very well by Sir already. We should also have OPN type of balloon on shelf if required. And always prepare the bed well, be it whatever types of modalities you are taking. And this is a very important statement. I would like to mention it again. Do not implant stent till the lesion is fully dilated in 2 orthogonal projections. That's what the mistake which we did in one of the case I wanted to highlight in the live in a box case. So such similar mistakes should be avoided. So please check in 2 orthogonal views whether the lesion is fully dilated or not. Then this is already covered in brief. Fibrous plaques, direct stenting, fibrofatty plaques. We again use a compliant and non-compliant balloons in smaller calciums. You can get away with NC balloons. The calcium score is more. That's where we need calcium modification devices. And the madam was mentioning about OCT and IVUS. Each of them its own advantages, but probably the very crystal clear pictures. The OCT has got a little more thing where the depth also can be seen. The problem with whether it's IVUS or OCT is, as Sir mentioned, the catheters won't go where you want it the best. Then probably sometimes you using the additional body wire techniques and things like that would be beneficial. But we want more improvisation on the deliverability of the catheters, which actually Abbott said the latest optics are they had done some modifications. So that's where we need to work more on rather than combining imaging modalities of OCT and IVUS, things like that. So this is a brief video which shows the connections. Some of them mentioned. This is basically it is self-explanatory. I will leave it. Once you get a click sound like that, once you turn it, and then probably this is what is recorded in cath lab. Then once you turn it, then probably it's all good to have a good assistant or good sister to do that and become very comfortable. Unless that is corrected well, you won't get the image on the screen. So that sort of things is highlighted once it is done well. Then we'll also show you the threading of the OCT catheter. That is the flushing of OCT catheter is also important, because unless it is flushed well, you won't get good quality images. And then you see that it comes out at the end. That is the light. Once you press it there, you get a fish mouth pattern. that tells us that the catheter is working well. This is a zoomed out picture of this catheter. For sake of time, I would go proceed further. One other important thing is, many of the times when you are putting the catheter in, you have a Y connector there. You keep it one stuck open so that the catheter can pass in easily, otherwise it gets kinked. I think it's get masked by my hand, but otherwise most of the things are pretty okay. Previously, to thread on the catheter on the wire was difficult, but the modifications made it easy. But when they increase the shaft length initially to make threading become easy, the catheter become more flimsy. That's how they modified this into new Dragonfly OptiStar. I don't know why that is not. This is the improved crossability, that pushability and the trackability is better. You have little more shaft and you can advance the catheter better without much of kinks. So that is a slight modification we've used in few patients. Thought it is slightly better than the older versions of the catheter. This is again as the calcium incidence increases, this grading, and I won't go into details, already covered. But risk stratification based on the more severe the calcium, the more will the event. That's what we need to keep in mind. See that sometimes this stent boost technique will works like poor man's IVUS. This is the picture which already shown circumferential calcium, 360 degrees calcium, shows it well. See that there is another patient where calcium is seen all around, shown by sir already. And calcium nodule, this is where we need to work on further. Though we have this orbital atherectomy, which is supposed to be good, but still sometimes the stents get underexpanded because of a very calcific nodules. This is where research is further going on. So this is already mentioned, the calcified nodules, people are trying IVL also. Then this is the recent SKY data showing that which one may be preferable for what. And the laser, this is atherectomy, is basically very easy to use. But the problem is the deliverability is a challenge. You need to take the balloon inside. That's where I think lithotripsy balloons are a challenge. Rotational atherectomy, the advantage again, the problem is you need training, some amount of training. Everybody cannot use it straight away. The orbital atherectomy is slightly more better than the rotational atherectomy, I feel. And these are useful in balloon uncrossable lesions. And then approach, a brief about it is as already covered it. And the deep calciums, that's where we tend to image and probably use. Combinations of this also could be sometimes used in patients. I would, this sort of Brad lesions, left main equivalents, are all that a pre and post just is made possible by using it. This is another 55-year-old surgeon came with total occlusion with a calcific nodule. We had to work a lot on it, then probably used IVL, the indentation of the balloon, which was there here, goes away here in the post procedure, and then patient had good result. That's how the shock wave is supposed to be predictable and has advantages of deep calciums. There's a system, for sake of some of you who are not exposed to it, we already have it, and the various lengths of the catheter balloons are also available, which are mentioned here. There's a definite method to avoid the balloon ruptures. I can't go into details, but basically delivery number of shocks also is increased now, the latest modifications. The modified balloon has two layers, which is less prone for rupture. Initially, when the earlier version, we had only single layer of balloon which was getting bursted. Now with the two layers, it's slightly better, and but it becomes more bulky. These sort of lesions, which are very multivessel disease, calcific disease, and patients request and to avoid surgery. That's where we take the help of multiple steps. For the sake of time, I will leave it. But one right coronary catheter, which has a lot of learning points, I would like to show that video which we recorded in the cath lab. This is again LED, LCX, all that was tackled well. Then we had used various combination of devices. Not going into detail. I will show you one once this is left and LCX is done. I always that we had a reasonably good result. That see the amount of armamentarium of the material which is used. This is another 64-year-old female had recent history of stroke, but good thing was the LV function was okay and renal function was normal. She had calcific disease like this, and then again, because of recent stroke, they wanted to avoid surgery. We did counsel them to tell them that this is a very bad disease in RCA and LCX, and see that in the ostium, mid-segment, everything was calcific disease. And that lot of patient.
Now we have
This is a
decided
live
to
in a
go
box case.
onto the right
I
coronary
request you
artery.
to see this.
So this is the right coronary artery picture now, which shows two levels of disease: mid-segment tight disease and the proximal disease. Now after finishing the left side, now we hook the right catheter.
Are you able to hear the sound, madam?
Because also the spasm and artery also looks small and 5 French JR catheter. As you see it there, the mid-segment long segment disease.
Are you able to hear the sound?
Proximal site stenosis. Another point I wanted to highlight this, and a team
The
we
sound
always
is coming.
practice this.
Yes.
Okay.
Is when you're doing multi-vessel PCI, operator could get exhausted, and it's always better to have another colleague who is equally competent and senior enough. So we always change. And now we become an assistant to the main, other second operator becomes the main operator. Now we go on to right coronary artery. Hopefully we should be able to pre-dilate and take care with a long stent. Because stent is still underexpanded even at 20 atmospheres NC balloon. There is some residual underexpanded balloon there, but we thought we have opened with 2.25, it could go. 38 mm Zines expedition tracked it so well, we thought the lesion is open. Then we positioned it well. Just we didn't want to cover the ostium totally because ostium was free from disease. We wanted to do it from the conal branch. Next. Then we expanded 14, 18.
That's another important point. We didn't check in the contralateral view. We saw it in one plane, it is opened. And then stent, such a long stent, we could take it in easily. And then once we deployed the stent, there was still under expansion seen.
But the residual waste at that point where we had a suspicion the balloon was persisting. We didn't want to come out totally. We withdrew the stent balloon little, not to have distal dissection. We covered the proximal portion, which was again not stented, with a guide and tried to do little high pressure inflations here, but it didn't work. Next. Then we have taken another NC balloon 3 into 10. We expanded. That went in easily, but the residual waste was persisting. That can be seen. We went on to further to take expand. Then the bigger balloon, we thought the balloon with Ironman like thing could help. We put a more stronger Grand Slam wire. Second balloon, second wiring also didn't help because basically it was holding at that bend. We took another thinner balloon. Again, this went, but the residual was persisting. We tried to do OCT at that point, but the OCT catheter was also not going easily. We at that bend. We took another.
This is the OPN balloon where we are trying to expand. See, at one particular point at 35 atmospheres,
balloon.
I think
Again, this went.
It expanded.
But the residual
so that's where it is saved.
We tried to do
highlighted that. See this initial balloon dilatations, and then probably I've made the PowerPoint slides on this. Stents again is taken in and deployed, expanded. See that central waste is not going. We try to dilate again with a balloon, then focal high pressure trying to dilate at 2.75 and still it didn't expand. Then body wire, second wire we were trying to take NC balloon. It wouldn't go, it didn't work. Luckily, after putting another Grand Slam wire, then we tried to take this balloon. See this poor man's Ivers like thing. We were trying to image, but the catheter was not going, couldn't take it. So that was a crass under expansion of the stent because of calcium there. Then we were dilating with the OPN balloon here at 40 atmospheres. We watch it carefully, and then that's where the waste went. So now here the balloon is totally expanded. See this on the left side, and the waste is there at 40 atmospheres. Luckily, it opened. So every time we may not be so lucky. And the problem, the other thing which we need to keep it in mind is the diameter of the balloon. We should take the optimal size or maybe quarter size less, because if you also take a bigger size balloon and inflate it more to high pressure, the more chance of rupture could be there. And that's how we could manage this with high pressure post dilatation. Then after that post dilatation, then we could demonstrate that is a pictures, freeze pictures. Then we could take the OCT imaging also later once it is done. See that good dilatation, final result was very good. See everything artery was fully open. And then we did OCT also. For the sake of time, I would skip that. But see that stent is very well expanded. If you want, you can go through it in detail. But the point where it was tight here, it has opened up well, and we had a final good result. So the point we wanted to highlight is bed preparation. Unless you see, if you have intravascular imaging or OCT, if you can take the catheter is good. Or at least in two orthogonal planes, you check whether the lesion is opened or not, and then only take the stent. With good quality stents might go inside, but you might land in trouble like that. So in the previous patient, the other vessels which I didn't show in detail, LAD and RCA with LAD and OEM. Here, We got stuck, and luckily with availability of hope, and the follow-up results will be good. Then the areas which we got, the proximal RCA again was good sized. This is a lesion point, still slightly less area, but we thought it is acceptable. And distally is 5.79. So that final stent apposition is also good, and that's how we could document. To conclude, basically, some of the points which I wanted to highlight was OCT and is a very useful modality. Probably IVUS or OCT, both you can comfortably use it. Osteal locations, that's where IVUS is used. That's where we selected some cases where that was used. And sick patients, LV dysfunction, CKD, probably IVUS scores over OCT, but OCT gives you more crystal clear pictures, depth of it, you can see it better. Lesion bed preparation is the most important with whatever modality you're using it. Finally, calcium has to be cracked, and inadequate lesion preparation will lead to the improper stent implantation as shown in this RCA patient vessel and preparation. But don't do it unless you prepare the bed very well. And availability of the required hardware is mandatory when we are dealing with such complex PCI. And IVL is the easiest in learning curve, but sometimes difficult to take it, but effective, but a little more costly. So that's how we need to become comfortable with these latest techniques of imaging modality. I think I've finished my 15 minutes. I'll just stop here. I'd like to mention to you all again, whoever is blocked through YouTube also, please block your date, July 25th, 26, 27, 26, 27, 28th, July last weekend. We're doing it. Dr. Martin Liana, Antonio Colombo, Samir Kapadia, all these people will be coming physically. We can interact with all of them. And again, thank you very much. Again, I request all the colleagues who have joined through here in Zoom platform directly, as well as those hearing on the web streaming on the YouTube channel, to spread this message and be part of this upcoming TCT 2024. I think with this, I'll stop, and we'll have some interesting cases. If there are any comments or questions by Rath sir or others, we'll take it. Otherwise, we'll go to case presentations. And thank you again for patient hearing. I'll stop sharing so that others can start sharing. Any comments or questions, madam? Or,
Very nice presentation, Dr. Srinivas Kumar. Only, hello?
madam, go ahead. Please go ahead, ma'am. Now you're muted again. Previously, you're audible.
Like you were stuck in the mid RCA. I was thinking at that time that next you will take IVL. I don't know, maybe it was not there on board or something. Rather than taking high pressure OPN balloon at 40,
No, we could do it.
You didn't think of trying IVL in that case. Intravascular
IVL is like always. IVL is a little expensive. That's why if you can get away with OPN, it's
because
always
you
okay.
struggled quite a lot.
And
So I thought,
with that also, if it was not opening, then maybe next option would be
next.
probably that.
Right.
That's it. Any comments? Shall we proceed?
Dr. Srinivas Kumar.
Sir.
IVL, the catheter is a little bulkier than rotation orbital atherectomy.
Yeah. IVL is quite bulkier.
That's bulkier.
It's quite bulkier. So it is, if the stenosis is tight, it will not go. You need to dilate it if you want to.
Orbital atherectomy goes, sir, whenever the balloon doesn't go also, you can take it because it keeps cutting and goes in. Whereas IVL is not like that. You need to at least pass on the 2 mm non-compliant balloon minimum for it to go in. That's how I think that once it goes in, it does the job, but it's difficult for it to deliver in the site of lesion. That's the challenge with IVL presently. Once it goes, it cracks easily. Okay. And I think with these comments, we'll go on to the individual case presentations. Now, what we thought of different type case presentations, what we selected is where in bifurcations, where rather than putting 2 desks, now we take the help of DEB also. So this sort of bifurcation lesions, I requested our colleague Dr. Ramya to present interesting bifurcation cases where DES and DEB is being taken is into use. Over to you, Dr. Ramya, for your presentation.
So you can see my screen, sir.
Yeah, screen is visible, Dr. Ramya.
Yeah, it's
Good
good. Go
evening,
ahead.
sir. At the outset, I would like to thank Srinivas Kumar, sir, for giving me this opportunity. So this is a very interesting case of a 60-year-old male patient. He presented with the complaints of exertional chest pain and breathlessness of 2 months duration. Previously, he is a known diabetic and he's also a known hypertensive. And he also is a known case of coronary artery disease. In 2013, he had breathlessness for which he was evaluated by a coronary angiogram and it showed a 50% lesion in LAD. At that time, his stress thallium was negative and he has been on optimal medical management. However, again, a CT coronary angiogram was done in 2021, that is 2 years prior to this admission. At that time, they showed moderate to severe triple vessel disease. However, the patient was asymptomatic and he was not willing for further evaluation. At this admission, the patient is hemodynamically stable. ECG was not significant. There were no significant ST or T wave changes. 2D echo showed mild hypokinesia of anterior wall with ejection fraction of 58%. His laboratory parameters were almost normal. There was a normal creatinine, sugars were well controlled, and hemoglobin was 12.8 grams per deciliter. So with this background, we proceeded for a coronary angiogram through a right radial route. So here we can see that the left main is normal and LAD is calcified from proximal to the mid segment. And at the junction of the proximal and mid LAD and D2, we can see a true bifurcation type of stenosis, which is a Medina 111 class type of bifurcation. There is a second lesion in the mid portion of LAD, which is about 70%. And in the distal LAD also, there is a 80 to 90% stenosis. So the same we can appreciate even in this radiocranial view, where there is a classical bifurcation stenosis, which is involving LAD and D2. There is a second bifurcation stenosis in the OM1, and the OM1 is dividing into 2 branches. Between the distal OM1 and the 2 upper and lower branches, there is a significant bifurcation stenosis. RCA is showing only mild disease and there is no significant stenosis in any of the portions. So with this, diagnosis of double vessel disease was done with a true bifurcation stenosis involving LAD-D2 and OM1 and its branches. So for this patient, a multi-vessel PCI was done after informed consent from the patient. So as we can see in this picture, there are 2 significant bifurcation stenosis, one involving LAD proximal to mid junction and a D2 ostium. And here we can see that it is 1-1-1 type of bifurcation stenosis. However, the side branch, that is the diagonal disease, is confined to the ostium and is not extending more than 10 mm. Because of this, because the disease is not extending deep into the diagonal, a provisional stenting strategy was considered for this case. However, because the side branch is significantly diseased, a drug-coated balloon was considered to inflate the ostium of the diagonal, and the stent was planned to be implanted in the LAD. Coming to the OM lesion, here we can see that the OM1 is dividing into 2 branches, and in both the branches there is a significant stenosis. In this lesion also, a provisional stenting strategy was planned. According to the EBC, a provisional stenting should be a default strategy in all the cases, and only when the side branch is compromised after provisional stenting, we can consider conversion into a 2-stent strategy. So with this planning, the patient was taken up for PTCA. The right radial approach was taken. The guide catheter which was taken was XP 3.07 French. First, the LAD and D2 were wired with the regular workhorse wires, that is a run-through wires. So here we can see that both the LAD and D2 were wired. Then the D2 osteostenosis, which was very tight, was first pre-dilated with a 2 into 10 mm Rayuri balloon, followed by a 2.5 into 8 NC balloon. After balloon inflation, there was good flow in the diagonal and there was no flow limiting dissection. Then the LAD lesion was pre-dilated with a 2 into 10 Rayuri balloon. Though the vessel looked calcified, there was good opening of the vessel with a balloon and further calcium modifying techniques were not adopted for this case. Thereafter, LAD lesion was stented with a 2.75 into 28 Science Alpine stent. Both the proximal and mid-LAD lesion was adequately covered. The ostium of the stent was extended across the ostium of the diagonal tube. The stent was then post-dilated with a 3x12 NC balloon. Here we can see the post-dilatation. Post-dilatation is important in any bifurcation stenosis because it is important to make sure there is good apposition of the stent in the proximal portion of the main branch. After the pot was done, D2 was recrossed. Here we used a BMW wire, which is a pre-shaped wire. So here we can see in the first video that a distal crossing was adopted because this is primarily a provisional stenting strategy. After recrossing of the diagonal, the lesion was again dilated. The stent struts were opened with a 2x10 and 2.25 into 8 NC balloons. So this is the image after the opening of the stent struts. Then the D2 ostium was treated with a drug-coated balloon. It is a 2.5 into 10 mm magic touch balloon was used. It was inflated for 60 seconds at 8 atmospheres pressure. After dilatation with the magic touch, we can see that there is good flow into the diagonal. After the opening of the side branch ostium, the main branch again should be post-dilated. So pot was done with a 3x12 NC traveler balloon. So this is the final result where there was here we can appreciate that there is a good stent opposition. There is no edge dissection in the LAD stent. And in the diagonal, there is no flow limiting dissection, and there is a good TME3 flow is established. In a similar manner, a provisional stenting was also adopted for the OM lesion. In the OM1 lesion, a crossover stenting was done from the OM1 into its upper branch, and good flow was restored. The side branch was not affected, and it did not require any further intervention. So the procedure was uneventful. There were no complications, and the patient was discharged after 2 days. The patient is doing well at follow-up, and he recently came for a visit after 6 months, and he is completely angina-free. So purpose of presenting this case is to introduce this new method where a provisional stenting with the treatment of the side branch ostium with a drug-coated balloon is being adopted as a novel method to treat bifurcation stenosis with significant side branch involvement. However, if the lesion in the side branch is extensive and involving more than 10 mm of the side branch, then a two-stent strategy would be a better option in those cases. The advantage of using a drug-coated balloon is that there will be less metal burden at the carina so that long-term restenosis rates can be reduced. But the main crux of using a drug-coated balloon is that, like already said in the previous two talks, lesion preparation is very, very important. Adequate pre-dilatation is a must. And also the balloon which is chosen should be at least 0.8 to 1 time the ratio of the artery so that adequate drug distribution can be ensured. Only a problem with the drug-coated balloon is that there could be some dissections, but most of the dissections, more than 40%, are minor and non-flow limiting, and these do not cause any problem in long term. And if the residual stenosis is less than 30%, or if we want, we can do an FFR, and the FFR is more than 0.8. These will not cause any problems in future, and they can be accepted. Thank you so much.
Thank you, Ramya, for showing this interesting case where one bifurcation was tackled with just one stent without doing much because there was not much of disease there in L6 OM. Other place, LED diagonal ostium only had tight stenosis focal. You highlighted that aspect. If it's long lesion in the important vessel, you could still take two-stent technique. But because only focal osteal disease, you did this, and preparation before taking DEB is important. That's what is also highlighted very well. And then deliver the drug to use it, and probably additional drug like additional to provisional stent plus drug delivery could improve the results further of the provisional stent approach. That's what we are looking at. And thanks for showing this interesting case. That's sir, any comments?
Only the size of the side branch is important. I think if the side branch is below 2.5, it's okay, but if it is bigger, I am not sure whether how effective will be, long-term effective will be this drug-coated balloon. You have any concern about the size of the side branch is big, diameter is big. Will you use drug-coated balloon or two stent?
That again depends upon the only when the side branch is big only we are bothered, no, sir, whether it is stent or a regulating balloon. But a focal osteal disease like this, even with a bigger thing, we are actually stenting the ostium with the provisional approach. Even the main vessel stent, that's why distal crossing, all that ostium is stented with the drug delivery. But as you agreed, as you said, if you have long disease in a bigger size vessel, more than 10 mm, that's where I think we are favorable to two stent
Not of the
technique.
length, but the diameter of the vessel.
Yeah,
Uh,
diameter is anyway there. If it is a small diameter vessel, we won't bother only. We just
That's okay.
like OM, how we do it, we
Because,
just stent it across. But bigger diameter only with a focal osteal. Yeah, agreed, sir. The diameter of the vessel indicates the size. You mean size and area of supply. The bigger the vessel, you need to take care. That point is well taken.
Very nice case,
Thanks
Dr.
again,
Ramya.
Ramya, for we are.
Very nice case demonstration of drug-coated balloon. I was just concerned about it. Suppose in case we have a dissection after the drug-coated balloon use, then mandatorily we need to have a drug-coated stent, drug-eluting stent. That is, of course, that is the second point. And when we choose the size of the drug-coated balloon according to the size of the bias, whatever branch we are this thing, giving the drug elution, that time we should
Yes.
have 1:1 size of the drug-coated balloon too. As you said clearly that we should have a correct way of putting the drug-coated balloon. We should have nice complete dilatation of the branch, so that during the drug-coated balloon use, we don't have to use very higher
Yeah.
pressures. Just go for the nominal pressures. So those things, if we take care, I think there is a very good chance of getting a very good result. And I have seen many reports and many trials they have shown from the European club, this thing, cardiology, and they in intervention cardiology, PCR and all, they have shown very good results with the drug-coated balloon. But for us, because of the, I think cost is less, much more than the drug-coated stent, that's why may not be using that much. But I think we should use more of drug-coated balloons for the benefit of the patient.
Yes. Yes.
Yeah. I think we need to move on, madam. Is Varsha logged in already? Varsha? He said he will present left main calcific disease patient. Dr. Varsha there? Otherwise, Ramakrishna is there. Varsha can present after Dr. Ramakrishna. If Varsha is not there, let Ramakrishna present. Over to you, Ramakrishna. We requested him to present osteal L6 and osteal RCA PCIs and with image guidance. Hello? Yeah, I think he's already waiting.
You're able to see my slides?
Yeah, I can see.
Make it full screen. Yeah, full screen.
Yeah.
We can see the. Make it full screen. Press that button below, TV button. At the right lower corner, you have a TV button. Press that.
Box-like thing, you put it there.
It becomes full screen.
Video stuff.
Hello, Ramakrishna?
Sir. You're able to see?
Yeah, you are not able to make it full screen. We are able to see the slide, but it's full screen. Full screen means the right lower corner small TV button is there. Press on it, it becomes full screen.
You already become full
On
screen.
your laptop.
Yes. Yeah. Good evening, everyone.
Now it has become. Go ahead.
Yeah. Thank you for giving this opportunity. I'll present some of the cases which we did in the recent times. This is about the case one. This is a 78-year-old female, diabetes, and she presented to us with retrosternal chest discomfort and epigastric discomfort since 3 days. And she was admitted to outside hospital. So she was echo was done, suggestive of inferior and posterior hypokinesia with mild LV dysfunction, and troponin was elevated. She underwent angiogram at outside hospital, and I will show you the angiogram. And because of that relative complex osteal lesion, she was referred here for further management. So we tried doing angiogram in the radial route. It's a little bit complex anatomy with like a relatively bovine arch. So we took a 7 French guide catheter, and with the help of the guide, the stiff wire, and we could able to negotiate the guide into the aortic root, because she's an elderly female. We don't want to touch.
Sir, you can mute your video because it might come better. It is breaking in between. I don't know what about others, whether your internet problem. Just mute your video. The audio will come better.
Okay.
Go ahead.
So we could able to negotiate with the help of stiff wire, and you can see the tight ostial circumflex lesion. There is another lesion in the RCA, and LAD is okay. So we cross the wire in LAD and LCX with the help first with the run through wire, and then the original plan was not to put a stent across, because osteal lesions are prone for again re-narrowing and restenosis within a short period of time. So because you can see the significant amount of calcium in the bifurcation part where the LAD and L6 osteal lesions. So initially run through wire, and then the run through wire was exchanged for the Viper wire for orbital atherectomy and the further treatment. This you can see this wire crossing, and we removed the LAD wire, and then orbital atherectomy catheter 1.25 bar was taken, and it was done almost multiple times across the circumflex lesion. So you can see the burr is moving across the ostial lesion. So with multiple, with each time it's up to 20 seconds. We did up to 5 to 6 times. So after doing, so each time we have to take a little bit in between, little bit break. This is after doing orbital atherectomy. You can see the nice opening of the circumflex ostium. And after that, again, we did another polishing run, and followed by we did a balloon dilatation of this is after doing orbital atherectomy. You can see slight amount of haziness at the ostium of the circumflex. We did IVAS, but I could not able to get the images in this. After dilating, we did balloon dilation again. The run through wire was crossed again. So we did balloon dilatation with 312 NC balloon. Sorry, complaint balloon. So after balloon dilatation, again we did 3.3 into 15 magic touch balloon dilatation. So again we did IVAS run. There is no significant amount of dissection. Non-flow limiting dissection was there, but again we did magic touch balloon for 1 minute. So this is a 3 into 15 magic touch balloon for 1 minute inflated. So this is the result after magic touch balloon. Nicely opened circumflex ostium, and IVAS was done. Area was more than 9. So there is no significant amount of dissection or so this was RCA lesion at the distal part. We did the stenting of this. So I'm skipping this because of it's not the topic of interest for this now.
Hello?
Sir. Slides are not moving.
Not moving. I think you should need to. Now you can go again.
Yeah.
Especially the LO caudal view also, the L6 ostium looked quite open quite well, and this could be another important approach in future. RCA anyways, mild
This
disease.
RCA is distal RCA, but this has also created a lot of trouble. We placed 2 wires and then we did with the help of Grand Slam wire. So this regarding another case is a 78-year-old male, diabetic, CAD post PTCA LAD almost 10 years back, and he was now diagnosed with end-stage malignancy and chemotherapy. He was using chemotherapy. Because of that, he was having very low platelet count. Platelet count is only 20,000, and luckily no active bleeding, and he is having recurrent angina with LVF, requiring admissions within a span of 1 month, 2 to 3 admissions. So we did angiogram for this patient. Similar case, almost like calcification in the distal L6 stent is patent, and you can see tight osteal lesion in the circumflex. RCA CTO. So his entire circulation is the posterior circulation is dependent upon the circumflex. So there is a significant stenosis in the circumflex and 60 to 70% lesion in the another lesion in the medial AD. We don't want to put a stent in this patient because of low platelet count, and his expected lifespan is also like less than 1 year. So we don't want to put a stent and long-term antiplatelet and anticoagulation. So for this patient also we did the almost same strategy of doing orbital atherectomy in the ostial circumflex and drug-coated balloon. So you can see in this there is a significant stenosis in the ostial circumflex. So in this the L6 lesion was crossed with Viper wire, and we did orbital atherectomy with a 1.25 bar and multiple times. So you can see the bar moving down the lesion. Even after doing multiple rounds also, this is still there is some amount of residual stenosis, residual narrowing just after the ostium. So we did non-compliant balloon dilatation with 2.5 into 12. So after NC balloon dilatation, we did 2.5 15 magic touch balloon. So this is the result after magic touch balloon. Still, there is some amount of residual narrowing, but ostium is clean. You can see in the caudal view. The LAD lesion we don't want to touch because we don't want to put a stent or we don't want to disturb the plaque at that point. So he is doing fine since almost 6 months. So this is another case. He's a 60-year-old male, diabetic, hypertensive, and CKD. Baseline creatinine is 1.8. So he presented to us with acute coronary syndrome. He is with anterior wall MI. So he underwent PTCA to LAD, primary PCA. So on screening, he was diagnosed to have ostial RCA lesion also. So you can see there is a significant tight ostial RCA lesion. And none of the guide is sitting properly like JR guide. So we took XB RCA guide for ostial engagement of RCA. So we did IVAS for this patient with a. So after doing IVAS, I will show you image. So after that, we did 210 balloon followed by 2.5 into 12 NC balloon dilatation. So this is the stent we are placing in the ostium. So you can see IVAS images. So this is from distal portion. There is some amount of calcification. This area is normal. There is some amount of narrowing in the middle. Again, there is a minimal plaque. So you are coming near to the ostium. The ostium is significant stenosis. The plaque burden is almost 80%. With area of only 2.5 or 2.75 millimeter square. So this is the ostial lesion almost. In the first image, we are coming almost near to the ostium with minimal amount of calcium, mainly fibrotic plaque. So we placed the stent across the RC ostium, and stent was inflated with 2 to 3 studs protruding into the aorta. So post stent we did again the IVUS. So you can see the final image. The well expanded and well opposed stent. The IVUS ostial area is almost 8 millimeters square. So the stent is well opposed. So in summary, the ostial lesions need a tailored approach for each patient, especially the ostial circumflex lesions, because high chances of re-narrowing if you put a stent across the circumflex ostium. So this is a relatively new strategy we are following, and there is one small study of 30 patients from India. They did the same thing for ostial circumflex. They none of the patients are having developed any complications at the almost 6 months follow-up.
Thank you, Ramakrishna. Hello.
Yes, sir.
Yeah, thank you for showing interesting cases. And LCX osteal disease is always a challenge for us. We are trying to search what is the solution. Probably orbital atherectomy with a regulating balloon could make it simpler, as well as if it works long term, it will be very good. There's no problems of doing complex bifurcations, again, LED getting involved. All that, both the two patients, at least ostium also quite opened up quite well in levocaudals. Ostium also showed quite big. So 6 months, I think 1 year, another patient, 6 months, another patient, both the patients are doing all right. The good strategy. If there are no comments, because we're running slightly short of time, we'll go to anybody wants to say any comments on this disease, what Ramakrishna has presented. Otherwise, we'll go on to next. I think Varsha, now he told he's logged in. He'll show a calcific left main PCI, and he had some issue post PCI, and let him share. Dr. Varsha, over to you. Hello. Yeah. We'll.
Hello, sir. Hi, am I audible, sir?
Yeah, we can see, make it full screen and go ahead.
Yeah.
There we go.
Yeah. Are you able to see my slides?
Yes, yes. Now
Yeah,
it's
sure, sir.
perfect.
I'll go ahead. Hi, good evening, everyone. Sorry for joining in late because of some technical issues. So I'm presenting a very interesting complication following a left main PCI using an intravascular lithotripsy. So this is a 63-year-old gentleman, hypertensive, non-diabetic, came with a class 3 angina with a recent worsening for the past 1 month. ECG and echo were unremarkable. So I'm actually showing the guider, 7F guider angiogram instead of the diagnostic angiogram, so just because it's clearer. So as you see, it is a left circumflex dominant system and a trifurcating left main involving the distal left main lesion extending into the LAD. And what is notable is the calcific tight osteoproximal left circumflex lesion. So which is always a challenge, and it is often the most difficult part to manage. So then you can see the cranial view and the right coronary artery, which is a very small vessel. So when we tried negotiating the OCT catheter into the circumflex, we were unsuccessful. So we've just done a left main to LAD pullback. As you see the panel on the left, there's a thick sheet of calcium at the distal left main, and the panel on the right shows the bifurcation point wherein you can actually see the tight calcific lesion in the left circumflex, that's the top of the screen, and the tight calcific lesion in the LAD. So the bottom line, this is a gentleman who's got a syntax score of 34 with a trifurcating left main disease in a dominant left circumflex and a heavily calcified vessel, all of which are really pointing towards a definite CABG. However, the patient was not diabetic, he was obese, had normal LV function, and most importantly was absolutely unwilling for CABG, was not even ready to meet the surgeon for an opinion. So we went ahead and did a intravascular lithotripsy guided angioplasty. So as you can see, we took a 3 into 12 mm balloon and we gave around 6 sets of pulses. So you see the panel on the right showing an eccentrically inflated balloon, just to show how tight the lesion was. So we followed that with a POBA with a NC balloon. And as you can see, compared to the previous slide, the left circumflex ostium had opened up significantly better. So we used the same intravascular lithotripsy balloon, and this time we did a left main to LED. The remaining 2 pulses were given, and following which this is the angiographic result after the intravascular lithotripsy. Entire 8 pulses were given. This is before the 12 pulse IVL balloon was available. So we felt in terms of sizing, the left main and the left circumflex seemed to match the size, and LED was significantly smaller. So we decided to do a 2-stent strategy straight away with a reverse T stenting to the left main LED. So we took the first 3.5 to 23 everolimus eluting stent, covered the left main to the LED. And then we post dilated it with the 10 mm balloon, especially at the tightest 3.5 mm balloon at the tightest point, followed by a pot with a 4 mm balloon before recrossing into the LED. So after the pot, recrossing was fairly easy, as you can see the panel on the left side. Following the recross, we opened the struts using a 2 mm balloon. And subsequently, we took a 275 to 28 mm everolimus eluting stent, and with a minimal projection into the left main as a reverse T strategy. As you can see, the stent boost, we had taken the panel on the right side, showing just the balloon marker projecting into the left main with the stent strut starting at the ostium. So this was the left main stent, and the panel on the right showing patent flow into the left circumflex with the stent balloon inflated. So following that, we did a simultaneous kiss with a 275 balloon in LED and a 3 mm in LCX, and finished with the final pot with a 4.5 balloon in the left main. And after so much effort, we could not let go of the left circumflex without doing a proper OCT assessment. So as you can see, we in fact took a support catheter guideliner to track the OCT into the circumflex, and you can see the OCT run on the right side along the left circumflex artery. I have a still image. I'll come back to that. So this is the final angiogram for the day, which is angiographically looking very good, and so was it on the OCT. So the panel on the left shows the left main area of around 11.2 millimeters, and the tightest portion in the left circumflex, we got an area of 7.5, which was fairly acceptable. Despite the eccentric expansion, in spite of IVL pulses, we couldn't achieve anything more. Subsequent hospital stay was pretty much unremarkable. Patient was ambulated and discharged in 48 hours. He had come back to us a week later with worsening dyspnea and fatigue, and this was the ECG showing a new onset atrial fibrillation with a fast ventricular rate. Echo showed a mild pericardial effusion. There was no tamponade physiology. So at that time, we decided to manage him conservatively. So as you can see, this is the CT. See the pericardial effusion along with bilateral thin rim of pleural effusion, which retrospectively, now in retrospect, it was possibly a systemic inflammatory response rather than a procedure-related event. So we did do a recheck angio to look for any leak, which led to the pericardial effusion, but there was no leak occurring anywhere. And actually note that the atrial branch, which was coming off from the left circumflex, is probably closed because of our stenting, which explains the occurrence of the atrial fibrillation. So at that stage, we made a provisional diagnosis of post-cardiac injury syndrome with a mild to moderate pericardial effusion, new onset AF with the acute kidney injury, which was possibly a cardiorenal or a contrast-induced nephropathy. We gave amiodarone infusion and gave a cardioversion, following which he reverted to sinus. We continued therapeutic anticoagulation in view of AF. Basically, we started him off on colchicine, and creat reduced after the AF was reverted. He had come back to us with a worsening pericardial effusion, and this time he had tamponade physiology, at which time we've actually done a pericardiocentesis. The culture cytology were negative and inflammatory markers were high. CRP was around 120 and ESR was 80. Subsequently, we added steroids and indomethacin for 2 weeks and 4 weeks respectively, and colchicine was given for a total of 2.5 months. At 3 months follow-up, there was a complete resolution of pericardial effusion, and there were no cardiac symptoms whatsoever. So essentially, the points we wanted to answer was why does IVL per se, does it really predispose to post-cardiac injury syndrome, and is AF manifestation, and how do we manage? So essentially, post-cardiac injury syndrome is a constellation of these three: post-MI syndrome, that's Dressler's, post-pericardiectomy after surgery, or post-traumatic pericarditis. So I'll just skip through the theory. I thought I'll just get to the, so there are a lot of things that are supportive to this hypothesis. There is a distinct latent period of a week before the patient actually worsens. There was a coexistent pleural and pulmonary infiltrates, and there was a prompt response to steroid and anti-inflammatory drugs. Of course, anti-actin and anti-myosin antibody correlation would have been ideal, but they were not available, for which reason it wasn't done. And only 1/3 of patients actually have a clinical pericardial rub. Most marked feature is the leukocytosis and elevated inflammatory markers. So there are quite a few prior published reports. This one was published from India, but as you can see, this occurred 4 hours after the procedure. So wire-induced perforation was very likely. And this is a publication from Korea, which showed a presentation within 3 hours of PCI. So all these essentially cannot exclude the fact that there could have been a wire-induced perforation. This is another publication from India, which patient presented 3 hours after the procedure. So the next question we were wondering was, does IVL per se predispose patients to post-cardiac injury? Most reported cases so far have shown occurrence in a high-risk procedures like CTO, long procedure time, high-pressure balloon inflation, use of hydrophilic wire, which leads to a perforation, and ACS, of course. So if you extrapolate the same science or physics of renal lithotripsy, there are multiple extrarenal complications reported with renal lithotripsy, like colonic perforation, hepatic artery rupture, splenic rupture, even aortic dissection was reported. So if you actually look at the amplitude of shock waves, the renal lithotripsy shock waves are around 30 to 100 megapascals, which results in almost 300 to 1000 atmosphere worth pressure shock waves. Whereas a coronary is a miniaturized version which emits only a 5 megapascal or a 50 atmosphere equivalent. But then if you actually look at the occurrence of post-PCI MI in DISRUPT CAD3 trial, which is the pivotal trial of intravascular lithotripsy, it was 7.3%, which is remarkably higher than a contemporary complex PCI series, which show an occurrence of around 1 to 3%. So if we actually extrapolate this, maybe this does predispose. So we did manage to publish this case. This is the first and the only case of post-cardiac injury syndrome following intravascular lithotripsy published with a distinct latent period and etc. So how do we manage this patient? The ideal NSAID of aspirin or ibuprofen can be considered, and colchicine there is basically a very low number needed to treat for this. People have used up to 3 to 6 months, and in refractory cases, you give start off with a 0.5 mg per kg dose of steroids and taper it over a month or two. We must note that there is a 10 to 15% occurrence risk of recurrence. So yeah, I would like to conclude by saying to watch for an occurrence of post-cardiac injury syndrome. It's an inflammatory response to heart antigens and blood in pericardium. It's very rare after elective PTCI, and so may commonly go undiagnosed. First line management is NSAIDs followed by colchicine. Yeah, thank you.
Thank you, Varsha, for showing interesting case. I keep telling both operator and patient needs to be lucky. Something like that where everything went well, you had some issue, but luckily managed well. Rat sir was trying to say something. Okay. I think any comments from Madam or Raidu sir? We will go to the final presentation. We are nearing our time. Any comments, Madam or Raidu sir?
Dr. Varsha, it was really excellent, immensely interesting, and you have done a real research work for this case, and I have seen that your publications are there for this case. I think we should learn, and we should also take your opinion for such, kind of very rare complications we do see, but we don't give much interest, and with the treatment, they just pass off, and we don't publish also. So for all these years, how we are practicing, we are always clinically oriented to the patient outcome and patient well-being, but very least oriented towards the publication and the academic part of it. I think that is the most important learning process. I think we are learning out of your experience and your presentations and I think as a group, we all should come together and make some good presentations for any kind of such cases, and we should discuss. Like previously, we used to have a good, cath lab meeting every Tuesday. I don't know, much before you came.
We will do, madam, because it's all lot of other people also logged in. It's not just Apollo, though we are doing it. Thank you, madam, for your encouragement. Thank you, madam, for your encouragement. But we'll discuss further, and more such meetings will help. And congratulations, Varsha, for the interest.
Thank you.
The last case for today's presentation is Dr. Gokul was supposed to present, but he was busy with some other thing. Dr. Zha, our interventional fellow from Myanmar, he agreed to present. We can present briefly. Anyway, he talks very less. Hopefully, he'll finish fast. Over to you, Dr. Zah, to show some graft interventions. I'll cover up for you. Don't worry. You can briefly present. Thank you for agreeing at the last moment also. Go ahead, Dr. Zah, for presentation. Make it full screen. Over to you. Go ahead. Unmute yourself. Muted. Zah, you're muted. You unmute. Go ahead. Yeah, go ahead.
Okay. First of all, I would like to introduce myself. I am Dr. Zoh from Myanmar, fellow of the Dr. Srinivas Kumar sir. Today, I would like to present about the GRASP PCI behalf of my team. The case is the 70-year-old gentleman presenting with the exogenous chest pain and the shortness of breath, no case of the significant triple vessel coronary artery disease. The patient shows CABG was 10 with 3 grafts. At that time, only grafts, SPG grafts was used, the LED, OM1 and the RCA in 2016. The patient also underwent before the CABG. There is the BDCA to osteoproximal LED, but unfortunately, I have no this data. And the patient also against after 6 years of the CABG, the patient present with the exertional dyspnea. At this time, grasp angio was 10 and the revealed that there is the stenosis at the osteoproximal part of the SPG to OM1 grasp. So PDCA was 10 in 2022. The patient also has hypertension as the CV risk factor. Recently, the patient had the echo review, only my hypokinesia of the lateral wall and the cost LVES with the 63%. This slide shows the baseline baseline investigation of the patient and the reveal that the everything within the normal limit. But from the patient had the mind normoformic normocytic anemia with the hemoglobin of 10.2 gram per deciliter. Though we want the coronary angiogram on the 90 February 2024. Here we can see that on the movie, there is tight stenosis in the proximal part of the SCH, and also there is another lesion in the mid SCH with the 99% stenosis. The earlier point of view showed that there is also stenosis in the OM2 at the proximal part of the OM2 at the 40 to 50%. We can see there is the ISR with the 100% stenosis starting from the posterior LED. Right-sided movie show there is the RCA with the additive vessel with the 50 to 60% stenosis at the proximal part, and there is mild lesion in the mid-arm distal part. There is also tight stenosis in the posterior BDA. Even patients used the Lima at the graph during the CABG. We did the Lima angiogram at the time. Lima is good and no problem at all. This movie shows. Last side movie showed the SPG do the LED crash is patent and nose problem. Those nothing stenosis. Right side movie show there is the SPG do RCA crash. There is the eccentric stenosis at the 99% at the posterior part of the SPG crash, and there is also another 60 to 70% stenosis at the anastomosis side. This movie showed the SVG to OM1 crash, and there we can see that it stand inside with there is 60 to 70% ISR at the proximal part of the SVG to OM1 crash. So coronary angiogram report revealed the patient had the significant triple vessel disease or the native vessel. Correct angiogram revealed there is SVG to RCA crash, the tight stenosis. Also, ISR noted in the SVG to OM1 graph. So we decided to do the BDCA and standing to the laminating to SCH and the PTCA extending to the mid SCA. Also BOBA with the DEV to the ISR or the SPG to 1 graph. So we did the approach with the right femoral artery approach with the we engaged to the left main LMCA with the HP3 difference. Then run through our place into the SCA to the OM2. We pre-dilated with the mid part of the SCA lesion as well as the proximal lesion with the 210 SC URI volume. Right side of the movie show there is the after pre-dilatation of the SCH. So replace first stand to the SCA to the OM2 at 2.5 18 millimeter with the only frontier to the SCA to OM2. We both dilated with the NC 2.75 12 to the stand. Also, we predilate with the NC volume to the proximal lesion. After deployment of the first stand, this is the condition of the SCH after standing to the mid SCH. So we proceed to the another standing to the LCH, but there the difficulty in stent delivery to the LCH. So we use the ground slant wire at the post for the stent delivery. Then we deploy another stent to the mid LCH with the overlapping with the previous stent. The stent size is the 2.75 18, only frontier to the mid LCH. So another step, we try to put the lemma into the proximal SCH. There also another difficulty in the stent delivery. So we get the hair or the ground slant wire again for the stent delivery or the lemma into proximal SCH.
Yeah, this result was okay. You show that the graft PTCA because we thought we'd discuss the graft PTCA.
Yes, sir.
Proceed further because for sake of time. Now you show this. Yeah.
Yes, sir. This is the final result for the SCH.
Next slide. Go ahead with this.
This is the POVA to the SVG to the O1 graph. We engage with the GR3.5 different to the SVG graph. We predilated with the IC3OH to the ISR. Right side of the movie show the post predilatation after the 3O NC volume. So we did the DEV with the POVA to the ISR or the stent 3O 15 millimeter for the 1 minute. The right side we show that there is the final result of the SVG graph or the ISR. Then movie also the another view of the ISR results. This is the procedure detail of the standing at the BOBA. For procedure, the patient is uneventful and the dishes after 2 days. This is another patient of the graft PCI today, recently done the gentleman 63-year-old male patient. I will only show the photo of this patient. There is also the SVG201 crash at there is the tight lesion of the osteoproximal part of the SVG201 crash. Predilated with the 210 volume, and we put the stent of the Zion by 3.528 to the lesion. There is the final result photo of the graph. Thank you for kind attention.
Thank you, Zah, for even sharing the final just in case we finished that and we came here
Yes, sir.
for the meeting. You presented that also. Thank you. And what the idea or principle was basically if you can tackle the native vessel, you always try to open up. That's what one of the venous graft to L6 was occluded. We opened it up, and wherever possible, if a second layer of stent, we avoid by doing a diverting balloon. Whereas in the last case today, what we did, the critical stenosis, tight stenosis was managed with stent. I think we are running short of time. Thank you for presenting at a short notice also. Before we close, any final comments by any of the panelists or my co-chairs or the other speakers before we close? Raidu sir or Tripti madam, anybody wants to say a few comments or any of my speakers who presented, Ramakrishna, Ramya, Varsha, anybody wants to say anything? I think Rat sir must be busy with the case. Anybody else?
Very good presentations from all the presenters and the speakers, and the topics and the points discussed in a very practical manner. And I must congratulate Dr. Srinivas for giving us this opportunity to learn every meeting, every webinar, lot of new points, new take-home messages, and to practically implicate in our clinical practice and the day-to-day cath lab practices. I would suggest you to have more number of webinars for most of our even PG students and those who can attend all the.
Yeah, I hope our postgraduates and all the junior the cardiologists also have the same enthusiasm like you. But in spite of all the thoughts, we still continue to learn and innovate and get our meetings more popular. And I think all the logins through YouTube as well as our doctors who participated, thank you for all the time. Request all of you to block your dates and be part of this TCT India South Asia in coming July. Thank you. If there are no further comments or questions, we close. Thank you very much once again.